So welcome to everyone to the launch of the special issue on developing health systems resilience in fragile and shock-prone settings, the findings from the ReBUILD for a Resilience Consortium. So which will be today, and we will try to keep you busy for 1.5 hours. Many speakers, so please listen. We have tried to reduce the numbers of slides, but still there are a few, and I'll introduce them. So first of all, meet us. We are the guest editors of the special issue, which is Kate Hawkins, Ibrahim Bououm, and myself, Egbert Sondor. Kate has been very instrumental and to the heart to organizing this whole webinar and preparing everyone so that you hopefully have a very smooth session today. Ibrahim will come on the floor a bit later during the sessions. He will lead the discussion at the end with the Q&A. And myself, I have the task to go through you with a few initial slides. We are the guest editors, which meant that we have been asked to review, to ensure that all the papers which come in, all the manuscripts which come in, have been reviewed and sent back to the authors and so on to ensure quality of the papers. And I think we have quite a few in, but some are in the final process, as you may notice later on during the slides. So first, for all of you who may not fully know or don't remember, just to fresh up, what is this ReBUILD for Resilience program, better known as R4R? It's a very long-term knowledge program funded by the British government. It started in 2020, but it was building on a predecessor known as ReBUILD, and it's kind of a continuation, but also a renovation of that program. And as you can see, it lasts up to 2026, and that's in fact kind of today. So now that the time has come to get all the knowledge together, and one of the ways to do this is to prepare this special issue. The R4R examines health systems resilience in fragile settings, experiencing violence, conflict, pandemics, and other shocks. And it has been implemented by an international consortium of organizations from quite a few countries. We have a group from Lebanon, from Myanmar, Nepal, Sierra Leone, and then 2 entities from the UK. And below on the screen, you can see their different logos. So all the activities of the R4R consortium has been around this primary research questions. How can we develop resilience capacities to ensure responsive, effective, inclusive, gender equitable, and sustainable health systems in fragile and shock-prone settings? As we all know, this is very hard settings, hard to be more resilient, but this 5 or 6 years has been to what can we do to build those resilience capacities. So today we hope to give you some answers, but there are many more answers. But today we focus on the special issue. We had planned to have 14 manuscripts representing much of the scope and activities and the findings of R4R, and all will be made available. Some are, 7 of them are, but the others will also soon be made available at this website of the Social Science Medicine website. But of course, there's much more material from R4R available, like policy briefs, like videos, and you can find them at the www.rebuildconsortium.com website. So the papers that have been published so far, we don't go through all the text at the right-hand side, but you can see quickly COVID, gender, research capacity, Tigray, cross-border, non-states, liminal health systems. It will all be explained in the next couple of minutes, but you can see the variety of topics which you can do under this consortium and under this concept of resilience. So what can you expect today? We're busy at the overview. Then when I finish, we have a short poll to ask you where you are from and what sectors do you work in. And then we will start with mini panels. You can see we have kind of 12 to 14 papers, and we can't have all the authors talking. That would be way too much and way too boring. So what we have tried to do is to group the different articles into a number of concepts, and we have decided to have a conceptual panel, a specific shocks panel, an actors panel, and a cross-cutting panel. So it's also not always totally clear cut, but this is what we do. I'll introduce them briefly hereafter. So from each panel, there will be 3 speakers, and they talk you through a number of articles they were involved in. Then at the end, we'll ask the co-directors of the R4R program, Professors Joe Raven and Sophie Witter, to reflect on the program and on some of the things they have heard earlier today. And then we continue with answering some questions via the Q&A. So if you have a question as audience, please already start listing them in the Q&A section of the Zoom facility. So we can group them a bit and get back to you in due time. Just a small preview of the panels. This is what we call the conceptual panel. It's Professor Fuad from Liverpool, Lydia Di Stefano from Community Partners International from Myanmar, Dr. Maria Bertone from Queen Margaret University in Edinburgh. Then we have the shocks panel. It's Marielle Horncastle, also Queen Margaret University. We have Marianne Musallam from Beirut. We have Chu Chu Tan from Myanmar. We hope that she can join. There may be some issues with technicality there. We have the actors panel, Ayesha Idris from Sierra Leone. We have Ala Dafala from the University of Oxford, and so Shofika Regmi from Hurt International from Nepal. And then finally, we have the cross-cutting panel, Professor Karen Diakonu, also Queen Margaret. We have Dr. Wessam Mansour from Liverpool School. And then last but definitely not least, we have Joanna Khalil from the American University of Beirut. So let's quickly start. So the first panel, please prepare yourself. And then this is the panel, and this is where they will talk about. These are the 3 papers they will reflect on. And as the first one to talk is Maria Bertone. Maria, the floor is yours.
Thank you, Ebert. And yes, I have a daunting task of kicking off the panel, and I will be kind of setting the scene to the broader ReBUILD research by describing the findings of one study, which is actually the last one in the list here, a study that we conducted using participatory research and with international NGOs working in fragile and humanitarian setting. And I can see some of the participants actually worked with us on this research, and one of the co-author, Jean Lee, is also on the call. And the aim was to understand the operational perspectives of humanitarian and development NGOs working in fragile setting on how to do health system strengthening in those contexts. And obviously what emerged quite a lot was the challenges that we well know about operating in those environments. But also importantly, and I think kind of also relating to the other findings of the whole consortium, some ways forward emerged. I'm going to just quickly summarize 3 points. I only have 3 minutes, and then give a little bit of an example from the Tigray region of Ethiopia. So first of all, one of the key findings was that for successful health system strengthening in fragile and shock-prone setting, we need to think and work outside of a box and to be very pragmatic and consider the local health authorities, whether they're formal or informal, whether they're recognized or de facto. We have to work with non-state actors, civil society, faith-based, and ensure their ownership and visibility. And these are the elements that will come back again from many of the other panelists today about the actor and the informality of the health sector and the health system in fragile setting. The second point was that health system strengthening must be intentional. It cannot be just a side product or a tick box. And to do so, funders, both humanitarian and development funders, must set up supportive environment for implementing agencies. And this includes the right balance of risk management and shifts in M&E and in indicator setting, and also a learning agenda on health system strengthening. And finally, Our work has stressed the overall importance of health system strengthening in fragile setting and in humanitarian situation. It seems obvious, but it is important to restate that health system strengthening cannot wait for situation to stabilize. It has to happen at the beginning, also because strengthening of a health system is path dependent. And if parallel systems are set up, going back, it would prove very difficult. And in addition, health system strengthening and supporting the resilience capacities of a health system is essential not only to respond to a crisis and to chronic stressors, but also to ensure preparedness for future shocks. And a second study that we conducted in the Tigray region of Ethiopia kind of illustrate these points. And it showed, in a very short nutshell, it showed that the resilient responses that we observe, some of them are effective in the short term to respond to the acute crisis, but may have negative effects in the longer term and for the recovery of a health system. So what is essential in this situation is to identify resilient strategies that can sustain the system functionality during the conflict, but also support the health system recovery in the longer term. And in Tigray, these resilience capacities appear to be related to the motivation and dedication of the health workers, to community trust in healthcare providers, and the regional health authorities' leadership. So to conclude, I think this first work that we're presenting give us some insights on the key findings of the overall work and something that Fuad and Lydia just now will develop further. And a key point is that health system in fragile and shock-prone settings do not always neatly fit in the existing frameworks or the traditional thinking about health system. Issues like weak governance, informality, contestation emerge as a key concern, but also in some cases as a source of resilience. And this is something that we need to think on. And I will pass it over to Lydia to expand on that and present the example of Myanmar and Thailand border. Over to you, Lydia. And thank you.
Thank you so much, Maria. Let me take you all now to the Thailand-Myanmar border, where amidst decades of ongoing conflict and exclusion from and limited access to national health systems, a cross-border health system, parallel from either systems, has emerged to serve excluded populations. In this system, a pregnant woman in a conflict-affected village in Myanmar might receive antenatal care from a community-based health service provider. She might then be referred to an ethnic health organization's clinic in a neighboring village, and finally cross the border to deliver her baby at a community-based clinic for migrants in Thailand. All of this without ever interacting with the national health systems in Myanmar or Thailand. Many populations residing in conflict-affected border areas have been systematically excluded from national health systems and face irregular or impeded access to public health. In Myanmar's conflict-affected areas, national health facilities are scarce, and in Thailand, displaced and migrant populations face systematic barriers to accessing care. As illustrated in the example of the pregnant woman, along the Thailand-Myanmar border, an ecosystem of different organizations, including those governed by non-state actors, ethnic health organizations, community-based, and nonprofits, have established a networked parallel health system that works to provide access to health services for vulnerable communities. This health system operates in what we call a liminal space, one that's across the border and between the national health systems of both countries. It works informally through flexible, dynamic pathways and in a decentralized structure. While this way of working presents some challenges, it also confers advantages that enable the resilience of the system. In the face of shocks, like the mass population movements to the border that occurred after the increase in violence following the 2021 military coup, the diversity in referral pathways, providers, supply chains, and other core elements of the liminal health system were a significant strength. Our recent paper, the one that's second on the screen here, highlights the various strategies for the health system along the Thailand-Myanmar border and the mechanisms that allow this system to remain resilient amidst adversity. The paper maps the key absorption, adaptation, and transformation strategies that allow this to happen. In short, our study shows that what works best in this context is decentralization and the ability for localized decision-making by individual patients and local organizations in communities. It's important to expand our thinking and understanding of health systems beyond just national health system frameworks and make sure that diverse health actors are also supported in providing healthcare, especially in fragile and conflict-affected settings. I'll pass it over now to Professor Fuad.
Well, thank you, Lydia, and thank you, Maria, for setting the scene. I will try to continue and build on your remarks. The paper that published here, so it's the first one here, so on rethinking cross-border in the context of mobility and for displacement. In fact, it argues that refugees and internally displaced population do not move only across international borders. They also navigate internal border lines, contested authorities, and areas of limited statehood. This means that global health policy must move beyond state-centric models and adopt a true cross-border lens, one that reflects how care is actually accessed, governed, and delivered across multiple authority and territories. The examples, that we touched in this paper are from Syria and Myanmar, and actually even examples from other protracted conflict settings shows that health governance is already plural. Non-state actors, local organizations, diaspora networks, and the humanitarian agencies are not peripheral to the system. They are often very central to it, especially when government are unable or unwilling to provide care. For example, in northwest Syria, humanitarian cross-border mechanisms, local governance bodies, and mobile referral networks have sustained services despite fragmented authority. In Myanmar, the same ethnic health organization, diaspora network, transitional supply chains have long supported border communities while population cross into the neighboring countries to seek essential care. So these experiences underscore a broader principles. Health system for displaced individuals should prioritize mobility rather than stability alone. Building resilience requires flexible financing, recognition of health workers across borders, and regional data system that can support continuity of care as people move. And if I should stick with one message, it could be like this. When forced displacement occurs across borders and political fragmentation, health systems need to be equally flexible, interconnected, and capable of movement. And I will stop here and, handle it to the second panel. Thank you.
Thank you very much to this first panel, and I think you more or less kept in time. So a great example for the others to follow. Let me move on to, if I'm capable of doing so, to the next panel, which is the shocks panels of Marielle, Marianne, and Chuchu. I'm still not sure if she's around, but we'll hear, and Marielle will start talking, and these are the three papers they will reflect on. Marielle, please.
Great. Thank you so much, Egbert, and to our three panelists from the previous panel. So the aim of our COVID paper specifically was really quite diagnostic rather than prescriptive. And instead, by documenting the experiences of community members and healthcare workers across contexts, we're helping to ensure that solutions are grounded in reality. I think that our role here is to make the underlying dynamics visible, particularly around burden and sustainability. So across the four settings that we looked at, we saw clear examples of what we can describe as absorptive and adaptive responses, maintaining essential services, reorganizing delivery, trying to keep things functioning as best as possible under really difficult circumstances and conditions. But when we look more closely, those responses were often being achieved through frontline workers taking on additional roles or community members adapting their care seeking, whether that be delaying care or sometimes paying more out of pocket. So at a system level, it can look like things are holding together, but then when you unpack it, that resilience is often being produced by shifting the burden onto individuals and onto households. And that's where it starts to blur into maladaptive responses because while those strategies work in the short term, they're not necessarily sustainable and they can deepen inequalities over time. So we also didn't see much evidence of transformation. Most responses were about coping within existing constraints rather than fundamentally changing how systems operate. For me, this links to a broader insight from our work, which is present in all of our rebuild work. It's that shocks are almost never standalone events and they're layered onto ongoing system stressors. And across the other papers, you can really see that in the aid cuts work. For example, the impact of the shock is shaped by long-standing dependence and prior crises. And then in the climate work, for example, you see both chronic stress and acute shocks, but it's coordination challenges that determine what actually happens in practice. So collectively, it shifts the focus from the shock itself to the system that it hits. And it also challenges the idea that resilience is about bouncing back because if systems are already under chronic stress, there isn't really a stable baseline to return to. So across these different shocks, what we're seeing is a consistent pattern, not just in how systems respond, but in who is actually absorbing the impact and what that means for sustainability. So I'll now hand over to Marianne, who can expand on this a bit more specifically in relation to some of ReBUILD's most recent aid cuts work.
Thank you, Marielle. So my intervention will further validate your conclusions. I'm going to present the main observations from a study we've recently conducted on another shock that fragile and shock-prone settings had to cope with, which is the health aid cuts. My examples come from 4 different settings: Nepal, Lebanon, Sierra Leone, and Somalia. First of all, the level of dependency is different in different contexts, and it's not only about the volume of the aid or the volume of the cuts, but also about what was the aid doing or the nature of the aid. For example, a country like Nepal, where aid was mostly supporting health system strengthening interventions, differ from Lebanon, where donors used to are financing around 80% of primary healthcare services. The first key observation was that the immediate impacts were observed across all 4 settings, including disruption in health service delivery, closure of facilities, withdrawal of UNHCR support for refugees in Lebanon, for example, transferring all the unfunded demand onto the already constrained public sector and households. Another observation was a common pattern with no immediate consequences, but with consequences expected on the medium and long term, which is the sacrifice of health system strengthening interventions for service delivery, so prioritizing life-saving interventions. And this is expected to reduce systems' capacity to deal with future shocks, further increasing their vulnerability. The third observation is the impact on the broader ecosystem, with NGOs, CSOs, and community interventions being highly affected because they're highly dependent on donor support in fragile and shock-prone settings. And this doesn't only mean disruption in service delivery, but also reduced social mobilization, reduced accountability, and impacts on health determinants more broadly. With regards to the responses of the different countries to these funding cuts, our observations validate Marielle's conclusions because we mainly observed absorptive and adaptive responses, particularly in Lebanon and Nepal, with the responses ranging from increased domestic funding. Also, the funding cuts triggered some policy debates for health system reforms, improved efficiency, better donor coordination. However, in more dependent contexts, such as Somalia and Sierra Leone, maladaptive responsive were observed, where responsive came in the form of reducing service hours, closure of facilities, prioritizing curative care over preventive care. And lastly, also a common observation is that we didn't observe any transformatory response. And this was particularly expected in our study because transformation requires time, which was not the case because the cuts happened abruptly. It also requires institutional capacity and a planned transition, which also was not the case. So that's it for me. I've discussed our observations from a study assessing one specific shock that affected all fragile and shock-prone settings, but shocks never happen alone. This is why I'm going to hand over to Chu Chu, who will be presenting the case of Myanmar, a country with multiple overlapping shocks. So over to you, Chu Chu.
Thank you, Maria. And Myanmar is a country which has faced multiple shocks of different natures within this 5 years of the consortium, and has been in many of our publications like Non-State Actors, Diaspora, and Liminal Health System papers. Myanmar had faced COVID-19 as of other countries in 2019 and 20. And then another political crisis with the military takeover in 2021, and a 7.2 magnitude earthquake in March 2025. Although all the shocks are different in nature, the compounded effect to the already fragile health system has been intense and severely damaging. The resilience of the community and community health plays like local health workers, ethnic health workers, other non-state actors response to the different and compounded shocks. And the absorptive capacity was not comprehensive, but more of an immediate emergency response, and with whatever capacity they have to serve the most in need. The different forms of coordination mechanism were also seen as adaptive measures. During the main political shock, without the government, with the non-government engagement policy and the sanction against the government, the funding was scarce and difficult. However, the collateral funding mechanism by the diaspora was impeccable to reach those in need for the health services, especially in the conflict-affected areas. Telemedicine mechanisms also helped the healthcare providers in hard-to-reach areas and conflict-affected areas to care for the most vulnerable people were also seen as an absorptive and adaptive responses. Also, flexible funding measures and M&E system by some of the international donors also helped us for better adaptive health responses. But as both Maria and Marianne has highlighted, the shocks are not alone, they are compounded. The adaptation was less formal and were more maladaptive and not really on the road to transformation because of the compounded nature and the disoriented government. So as health system researcher, when we think of the health system in fragile and shock-prone settings with multiple shocks like Myanmar, and which is also seen in many countries nowadays, transformation is not an easy process. But we must also think out of the box to understand the different coordination mechanism of the non-state actors, how to collaborate between different actors, not to leave the most affected internally displaced persons and stateless people. As international aid is shrinking, the role of diaspora needs to be also considered as an alternative funding mechanism. We must ensure that collective effort needs to be bring into fragile and conflict settings when we think of the health system building. And we must always, as a researcher community and workers in the fragile and conflict settings, we must take on to collective and also collaborative manners to take on the lessons learned from these studies. Thank you.
Thank you very much, Chu Chu, for your elaboration and together with your other members of the team. So we can immediately move on to our next panel, which is the actors panel. It's Ayesa, Ala, and Shafika. So please go ahead. I think Ayesa will start, and they will talk about 4 papers which are listed here. Alesha, please.
Thank you very much, Egbert. So I'll start the panel discussion focusing on the non-state actors and trying to introduce the whole panel. So basically in fragile settings, it's a bit different, wherein health systems are not held together only by the formal institutions, but by actors that we often fail to see and often fail to govern well. These actors include a wide range from non-state, such as private, for-profit actors, non-governmental organizations, civil society organizations, members from the diaspora, community leaders, up to informal providers, health providers. What our work shows is that these actors are not an alternative to the system. They are the system in practice, especially during shocks and chronic stress. They're already delivering care, as demonstrated in our work in Myanmar, where displaced health workers in the border areas continue to provide care informally, supported by diaspora networks, helping to address critical workforce shortages. Similar patterns were also seen in Lebanon, where Syrian refugee health workers filled gaps in overstretched systems and support vulnerable populations. Also, these actors or non-state actors often provide first and sometimes only point of care where formal services are limited or absent, as seen in Sierra Leone during the Ebola outbreak, where these actors were not only providing care, but also supporting community mobilization and responses. We also worked with community leaders in 2 districts in Sierra Leone, where they contributed to more resilient locally owned health and improved uptake of services through culturally grounded communication and mobilization. Community leaders also strengthen accountability and responsiveness by enabling two-way dialogue, surfacing community priorities, and supporting early detection and local health intelligence in their communities. Our work also highlighted both strengths of these non-state actors, such as local trust, flexibility, and resource mobilization, and also risk, including fragmentation, duplication, and unequal power dynamics, and also some risk associated with inadequate governance, such as inequity, variable quality, and unregulated practices. The implication here is clear that resilience does not come from exclusion and parallel systems, but from structural or structured partnerships, inclusive coordination, and smarter governance. So the question for all of us is simple. Do we continue to work around these non-state actors, or do we design systems that actively work with them? My colleagues will share further insight on how our work demonstrates ways to leverage their strengths for resilience while managing potential risk, particularly through more structured and coordinated partnerships. Over to you, Shofika, to share insights from our Learn Insights and the wider HRH work. Thank you.
Thank you, Aisha. Yes, just reiterating the points that Aisha just mentioned, that when we talk about actors in health system, we mean the people and the relationships that make the health system to perform the day-to-day work more effectively. So we mean the managers, the health workers, communities, political leaders, partners, and various other diverse actors within the system. I want to put shed some light on the second paper that is listed here. So in ReBUILD, we implemented 4. In ReBUILD, we implemented 4-year embedded learning site research in Lebanon, Nepal, and Sierra Leone that aimed building resilience capacity of the local health system. Through participatory action research and co-creation approach, we worked together with the local health system. So one of the big insights coming from these learning sites is that governance is deeply relational. So it's the trust between actors that shape how the health system performs. And it's not only the formal authority, structure, and resources, but the trust and relationship that is building on within the system. So the research also contributed to strengthen the adaptive capacity among managers, the mid-level actors. We engaged with them not only as implementers of the health system functions, but as people who translate the evidence generated routinely into actions and apply learning in their real decision making. Another key insight is about the political leaders, where we see them as not someone as outside to the health system, but as key central actors who shape priorities, resource allocation, and accountability, and they can influence the health system functions. So this paper again highlights how engaging political leaders bring positive results for health system resilience, as seen clearly from the case of Nepal and Lebanon. And there are communities whom we see as an active actors. So we didn't limit them as the beneficiaries of our research, but we engaged with them as key actors throughout the research process, from design implementations and together generating outputs and evaluations. So when we empowered these local communities, taking examples of Sierra Leone, they were very influential in terms of ensuring the accountability, service uptake, and the legitimacy of the district health management team in Sierra Leone. We have done a huge body of research in health workforce within ReBUILD. The third paper is what I'm talking about. So we implemented several studies in fragile and shock-prone settings, such as Lebanon, Myanmar, Pakistan, Yemen, Turkey, Tigray, Sierra Leone, and Nepal. And these studies just highlighted how health system responses during crisis supported the health workforce. In these studies, health workers consistently emerged as the critical point of system. So they are in the front line, the ones absorbing shocks, managing the responses, and keeping services going under the extreme constant situation. So whether during conflict, epidemics, or political crisis, it's the frontline mid-level health workers who end up holding the system together in practice. So the health workforce study summarizes that a resilient health workforce enhances the resilience of the overall system, whereas the resilient health system in turn strengthens and sustains the workforce resilience during period of multiple crises. So establishing supportive and systemic mechanisms to protect and empower the health workforce is therefore very essential for advancing overall health system resilience. Now, I'd like to invite our colleague Ala to present more about the diaspora and in supporting the health system resilience. Over to you, Ala. Thank you.
Thank you so much, Sofika and Aisha, for laying the scene. And I think, so interestingly, the diaspora strand wasn't one that was originally planned in the ReBUILD research, but it really originated from practical observations across several of ReBUILD case studies, that the role that diaspora were playing in supporting communities, but also health systems across Myanmar, other settings like Lebanon and Syria was quite monumental. However, when we took that observation to literature, be it, health systems literature, but specifically resilience literature, there was frankly very limited or none at all research that examined the role of diaspora in supporting resilience of health systems in fragile settings. And so that prompted our line of inquiry in this research strand, and we were asking three simple questions. Firstly, how do diaspora contribute to resilience capacities? And then secondly, how do they engage? Because again, unlike other non-state actors that are, locally embedded and active, diaspora are transnationally dispersed, but yet very, present and hand-in-hand working with local actors. So understanding engagement was critical, also because it's a practical entry point. And then thirdly, we were interested in factors that shape and affect that engagement. And so, and yes, we were looking at Sudan, Sierra Leone, Myanmar, Lebanon, and Nepal, also global literature. And this is the paper that is part of this supplement, where we did a scoping review of literature. Now, the findings are quite rich. I highly encourage you to look at the paper, but also stay tuned for a separate special issue that comes with the empirical research in our study. But if I would summarize, the key three findings from our research is that diaspora are critical actors in supporting health system resilience, and they support multiple resilience capacities. They draw on financial capital, so these are forms of contributions like remittances, but also, interestingly, philanthropic donations, investments in healthcare facilities, and also medical supply donations. We also see human capital contributions, which includes supporting service delivery, whether physically through medical missions or increasingly, especially in conflict-affected fragile settings, through virtual modalities and also workforce training. And finally, which was also a really striking finding in our research, is that the intangible contribution, which is social capital, the collective networks and resources that diaspora leverage and utilize, is foundational in enabling both financial and social capital contributions. And when we looked at their effect on resilience capacities, diaspora contributions largely supported the health system's capacity to absorb initial effects of the shock and to adapt, but less so to transform. And we interpret that as potentially because of a gap in governance. So the more countries are able to govern and direct diaspora contributions to strengthening resilience capacities, the more likely we will be able to see transformative effects. And now, in terms of the second key finding, is that engagement of diaspora, just as other non-state actors like Halima and Sofika did say, is quite informal, relational, and trust-based. Across fragile settings that we looked at, half did not have mechanisms to engage their diaspora, and where mechanisms were present, they were poorly operationalized. Also because we know fragile settings have weak institutions in general. And so when we come to the third key finding that we're contending with in our studies, that despite the critical contributions for health system resilience, they remain under-recognized. And when we look at the global landscape of shrinking aid, diaspora also represent untapped potential for these countries. And so we're excited to see increasing policy momentum around the area, and also excited to continue working on this, but thank you.
Brilliant. Thank you, Ella. Oh, I'll maybe move on to our last panel, where we're trying to summarize some of the cross-cutting themes that have come up from our work. And mainly what we want to reflect on are some of the themes that stand out to us, but also the methodological and maybe the research process related lessons that we have learned. So I will be reflecting mainly on what we've learned about shocks, and you've heard from all of my colleagues. They've been reflecting a lot on the different types of shocks and also stressors that all the countries that we have worked in have been experiencing. And across those, we really wanted to ask ourselves, what can we learn if we were to typologize these different shocks, but also what can we learn about the different responses that health systems and connected systems put in place? And I think there's a couple of things that really stood out to us. The first is, as you've already heard across the different examples, that absorptive capacities of systems are often overwhelmed. So essentially in fragile and shock-prone settings, we often see that absorptive capacities have already been depleted by numerous different types of shocks, and so therefore adaptations are actually much more common. Now, adaptations are often very welcome because they help sustain health service delivery, but also they might deepen different types of inequities. They might exhaust, for example, healthcare workers or others involved in responses, and they are highly contextually dependent on what can be relationally really brought together in terms of resources. One of the other lessons that we found was that health system transformation, in order to promote resilience, is incredibly difficult. So whereas we've seen examples, for example, in Nepal and where we have learned from previous shocks and where, for example, new mechanisms for action for new epidemics might be put in place, or even for climate-related responses, this is not always possible in other types of settings, mainly because of political constraints, resource constraints, but also because relationships and trust have been diminished between health systems and other actors. So essentially, if we reflect on the lessons around shocks, we have to understand that all the responses are really deeply contextually and politically mediated, and may also sometimes be maladaptive, again, as you've heard from the previous examples, and may compromise equity. And because of that, I'll now invite Wessam maybe to reflect on some of what we've learned in relation to that.
Thanks, Karen. And I think building on what you have just presented, I will start by explaining how in ReBUILD we ensured a mainstreaming of gender equity and justice concepts across our research and practice within these contexts of fragility and multiple shocks. So we didn't consider these concepts of gender equity and justice a cross-cutting add-on. Instead, we treated them as a core analytical and operational lens that shaped how we understand health systems. So we used an intersectional approach to capture how gender interacted with other dimensions of fragility, such as displacement and refugee status as seen in Lebanon, or disability inclusion as highlighted in our work in Myanmar, as well as professional hierarchies to structure health workers' experiences and access to services. So evidence from ReBUILD shows that without this lens, research and intervention risk overlooking the most marginalized population and exacerbating the already existing inequities. And moving to health workers, whom many of them are women, they are central to resilience but remained undervalued. So we found that across our contexts, women health workers, including close to community health providers during COVID-19 in Lebanon, Nepal, Sierra Leone, and Myanmar, as well as health workers in protracted conflict in Yemen and earthquake response in Turkey, they all sustained or contributed to the sustainability of service delivery during major shocks. However, they faced disproportionate workloads, increased risks, and limited recognition and support. So strengthening resilience therefore requires actively supporting, protecting, and valuing their roles through improved working conditions, recognition, and advocating for their rights. The next message is that gender is foundational to health system resilience, and resilience is not gender neutral. Actually, it's shaped by how systems manage power, rules, and resources under stress. And our close to community work in Lebanon and Nepal shows how gender norms shaped workforce dynamics, decision making, and service delivery, influencing the ability of systems to absorb, adapt, and transform during crises. Finally, our learning sites demonstrates how gender transformative approaches can be operationalized in practice. So, through participatory action research, learning sites in Nepal and Lebanon provided a platform to translate gender equity and justice principles into action by engaging women health workers and communities as agents of a change and co-producing contextually grounded solutions. These approaches contributed to strengthening local health governance in ways that support more adaptive, inclusive, and sustainable health systems. And now moving to another cross-cutting theme, the capacity strengthening, and over to you, Joanna. Thank you.
Thank you, Wissam. So at the start of ReBUILD in 2020, we established a capacity strengthening working group with representation from all the countries, Lebanon, Nepal, Myanmar, and Sierra Leone. And the main role of this working group was to guide research capacity strengthening across the consortium, ensuring it remained relevant and responsive. So our work in this paper was analyzed using a framework for capacity strengthening for health policy and system research, but it was adapted to reflect the realities of fragile and shock-prone settings, placing a stronger emphasis on iterative learning and adaptive management of the working group. In this context, capacity strengthening cannot be linear. It has to evolve continuously alongside changing needs and crises. And crises, as we have seen from our colleagues, were certainly a defining feature during ReBUILD period, starting from COVID to the ongoing conflicts and political instability in Lebanon and Myanmar, and of course, economic collapse and crisis. And one of our key adaptations was, of course, shifting those trainings to online activities. And it was initially a necessity, but this proved to be a pragmatic and really effective solution that allowed us to maintain the momentum and sustain collaboration across countries despite the major disruption. And over time, we expanded the scope of the capacity strengthening, and we introduced a dedicated session on safeguarding and mental health because we recognize the emotional toll of conducting research in fragile settings. And this was not just an add-on, it was really essential. We needed support to become really a part of our strengthening capacity of our skills and adaptation. So, and capacity strengthening activities did not stop at the individual level. The skills and knowledge, they spilled over into organization of the partner countries, strengthening the institutional practices. And critically, also, we invested at the community level, training our local partners to actively engage in research processes. And this became particularly evident in Lebanon because the Bekaa area where our learning site was based, there was periods of armed conflicts and bombardment, and we couldn't access the area. So our trained embedded researcher from the community was able to continue the work, and this ensured the continuity with minimal disruption. And it was a powerful example of why locally embedded capacity matters, not just for ownership, but for resilience during crisis. And as Wissam mentioned, gender equity and justice were integral part of all ReBUILD work, and especially capacity strengthening. We emphasized the shared leadership and the multi-directional knowledge, recognizing that expertise does not move in one direction, especially in the context of a consortium where we are multiple countries adapting to different shocks and crises. So the learning experience was really multi-directional. And another example is the establishment of early career researchers. It really functioned as a peer support network and space for mutual learning. And we were engaged in co-facilitation, and we really provided opportunity for hands-on experience while also reinforcing shared leadership across seniority levels. To conclude this paper, that what we have learned in that capacity strengthening in fragile settings must be really adaptive, inclusive, and deeply contextual. It's not about building skills, it's about building a system that can withstand and respond to uncertainty. Thank you. Back to you, Egbert.
Thank you very much, Khalil, and also thanks very much for the previous panel and this panel to bombard us with loads of ideas and thoughts and thinking. So I think you must have a number of questions. So please think about posting a question in the Q&A button on your screens. You can find it, and we'll address them a bit later on. But first, we would like to invite Joanna and Sophie, the co-directors of the program, to give their views and reflect a bit and also see if there's some key lessons to be drawn. So first of all, Joanna.
Thanks very much, Egbert, and thank you very much to all the panelists. It makes me very pleased and proud to hear all of these different findings across the ReBUILD programme. So ReBUILD has really generated a huge amount of evidence over the last 6 years, as shown in this special issue and on our website as well. And a real wide range of topics on health systems resilience. There really is something for everybody here. My second point is about, I want to really stress the value of evidence. Resources are getting tighter and tighter, and there is a risk, and perhaps already a reality, that research is seen as a luxury and resources aren't allocated to research. We are losing data streams already. But we do need evidence on what works and what doesn't work and why, and then allocate resources to those interventions, practices, programs that work. And this is what this special issue does. It provides that evidence at the moment. But we need to continue to promote the value of research, especially in fragile, shock-prone and conflict-affected settings. So my third point is that we've conducted a body of work that has focused on the health workforce, as Shafika explained earlier. But some key findings that have emerged and that are critical are that the health workforce is at the core of health systems resilience. We see this as a reinforcing loop. A resilient health workforce increases the resilience of the overall health system, whilst a resilient health system will strengthen and support the health workforce to be resilient at the times of shocks. And this means that putting in place supportive, systemic responses for the health workforce is essential. We all know health workers' resilience is often remarkable, but relying on individual strength or informal coping mechanisms is unsustainable and risks exploitation of health workers. Over time, individuals become more and more mentally and physically stretched as absorptive capacity at individual, team, and system levels is exhausted. This is commonly when maladaptation occurs. So health systems cannot rely on unpaid labour, health worker sacrifice, or family support. The health workforce requires a package of support, including a gender lens that includes fair compensation, recognition, safe conditions, training, psychosocial support, and supervision in preparing for responses to shocks and crises, and also during the crises themselves. So those are my 3 key messages: huge amount of evidence, the value of evidence, and the health workforce core to resilient health systems. I now want to hand over to Sophie for some more takeaway messages from our ReBUILD programme. Sophie.
Yeah, thanks, Jo. So a very rich panel, a lot to get your heads around. And I think what I'm going to try and do, if you can put up the next slide, Egbert, is just to, bring some reflections on how it all comes together. So when we started 6 years ago, we had a kind of conceptual framework focused on resilience, which picked out some of the areas we thought were really important from the literature and from previous work we've been involved in. And what we've effectively been doing is refining that now. We've just had the joy and the massive task of trying to write a paper based on 75 papers that ReBUILD has produced to bring together this whole kind of body of knowledge. And in doing that, we've also reflected on the framework and enriched it. So the slide you can see in front of you now is trying to pick up some of the key components that have come out. And hopefully a lot of these will look familiar from the panelists you've just been hearing from. So in the middle, you've got the health system core domains, which we started with, but we've kind of elaborated a bit more. What are the features of them that are really important for resilience? So it's around the effectiveness of the planning. It's around the availability and the flexibility of physical and financial resources. Also, of course, very important area around culture of learning and learning spaces across and within systems. The health workforce that Jo's just been talking about, of course, absolutely crucial, but also monitoring of the environment, using information systems effectively, reconfiguration of service packages, very strong messaging coming out around the importance of these wide and deep social networks and collaboration, which actually comes out of almost every study, this issue of really the importance of partnerships. But also of course, the important governance areas around dedicated values-based leadership, distributed control, accountability, and transparency. So we've refined those. And one of the messages that comes out is when you look at those, one of our questions, because we also started with 10 hypotheses, which we've just reviewed, so I won't go through with you. But one of the questions is there a really crucial element in these? And actually, when we looked at the studies, what was very clear is that they don't really work in individual units. I mean, this has always been a critique of the WHO building blocks as well. It's how they are combined and how they work together, which gives you your resilience or absence of it. So that is kind of message number 1 that comes out of our learning across the piece. The second one is really the importance, if you see it then going down the framework, it feeds through into this absorption, adaptation, and transformation that you've heard a lot about. And that feeds through into the health system, the community capability and responses. And looking across the studies, it's really clear that those relationships between the system and the community capability and responses is absolutely crucial, that they work together, they bounce off each other, they reinforce it or supplement for each other. and that resilience also resides in making that relationship stronger. Another important message, that's really message number 2. When we, as you've heard quite a lot of the people say, transformation is very challenging in these fragile and conflict-affected settings. So one of the messages that comes out is really around the challenge of transformation and the way that that can tip then where there are problematic responses into maladaptation. And the way we see that in many of these settings is in the form of increased community burdens, burden shifting onto the lowest cadres of the health workforce, increases in user fees, for example. So that is why the gender equity justice is particularly central, and we've made it even more central in this version of the framework, because the equity of who bears the burden of resilience is really a key issue that's got to be integral in how we study it. So I guess that's message number 4 or 3, I don't know, lose track. Then the other thing that's interesting about the framework now is around the edge, you have a number of these, what we were calling connected systems, and we've really built them up compared with the original framework. So it became clear, if you look at the top left, that the political, the cross-sectoral, but also political aspects like decentralization are absolutely crucial to the way the health system functions, and that's been very much a story we've been following in Nepal, for example. But also coming down to the bottom left, these cross-national systems, particularly aid, debt, trade, we kind of knew about those, but this area of the diaspora has really come out strongly, as Ella said, and we've been trying to follow what that means, how we support it. On the top right, you've got this area of cross-border flows, people, and this contested spaces, and that's a theme that really came out organically out of the work. It wasn't really written into our original framework, but clearly it's very important to how the system works. And then, so I guess the message related to those is that these are a key part of resilience. So what a health system can or can't manage depends on how it works with these connected systems. And then finally, looking at the bottom right, this area of relational patterns, relationships, the way those are built up through history, how trust is built up, legitimacy, or it's undermined, is crucial to resilience, because all of these capacities and capabilities that the panelists have been talking about, they're not just technical, they're also relational. So for each of the blocks, we have some practical messages, but I think those are probably the 4 or 5 really key cross-cutting messages that come out from most of our studies. So back to you, Egbert.
Thank you very much, Joe and Sophie, for this elaboration and highlighting some key points. You can imagine how much work it must take to get you in this so-called cross-cutting paper, which is also to be produced and also be included in the special issues in the end. As you have seen, we have presented most of the papers which are ready or about to be ready. We are sure that we also get in communication with you to announce when new papers are being added to the special issue and so on. So for now, we like to give the floor to Ibrahim and to see if we could have a debate with you, the audience, or audience who has been listening for over an hour now, and see if we can answer some of your questions. So Ibrahim, please go ahead. And for the audience, please add your questions if you still have any. Ibrahim.
Thank you. Thank you so much, Egbert, and really thanks to Joe, Sophie for the discussion, but also to all panelists for their insight. I will start with actually asking Sophie and Joe to answer. Joe already answered in the panel, but if you'd like to add something about the what next. So really there is a interesting question in the Q&A box about where does this research agenda need to go next to build on ReBUILD's important findings. In other ways, and especially now, Sophie, when you summarize this, what should come next in terms of the key priorities? We have a lot of researchers on the call, and really, what should be done? And I know, the tension, and it's not an easy question, So ReBUILD for Resilience focused on local health system, on that dynamics, but also you highlighted the tension between community systems and other systems. So yeah, what is the next? What's the research agenda? Easy to make it in 10 seconds. What's your research agenda for the next years for us and the research community?
I mean, I think I'm sure everyone will have their own answers. Maybe firstly, just to reiterate Joe's point, which is that actually getting resources for the next stage is a massive challenge now. And so protecting that space for research is really critical. In terms of the actual content, I mean, I think we have, as you said, we've tried to look in a very grounded way with a focus on what can we do, and we try and bring out those messages. But there's definitely room for testing more approaches and methodology. A lot of our work has focused on this learning site methodology, which is a participatory action research, and we think it's generated really good results. But now taking that to scale is the next challenge, and we have tried to contribute to that in bringing out tools and toolkits in most of the settings that can be used. But I think working with partners now to expand across other areas and seeing if you can expand the successes that were achieved in the limited localities would be really important. So I would say that's one thing. And certainly on some of the other areas, what we've highlighted is possible ways of strengthening, but they still need testing. So for the diaspora, for example, essentially we've just started the field and we've said we think these things will work, but nobody's tested them yet. There's no intervention testing that's looked at better engagement of diaspora. It doesn't exist in relation to health sector. So there's plenty to do in terms of actually designing and running and testing some of those areas that we're proposing as policy recommendations. So yeah, no lack of things to do, but maybe lack of money to do it.
Yeah, I think that's the big issue, isn't it? But I also think that what was coming out from the panel sessions this morning is that there's a lot about absorption and adaptation, but there's not much. There were not that many examples of transformation. How do we shift that kind of dial towards transformation? What works to make things sort of like embed within systems as well, so that we're sort of kind of like learning. We talk a lot about learning health systems. We really need to work out, how do we learn? How do health systems learn? How do they embed these sort of practices that really work, so that we're getting, the systems are getting stronger and stronger as we move through different crises.
And some of that will take a more longitudinal approach.
Yes. Yeah, definitely.
We did want to look at what changed during COVID and what stuck, but then you've got to have a longer timeline. So I think we would put in a plea for the teams that are working in our partner countries to be supported to continue that and actually follow the story on a longer term basis, because that's when you'll know what the longer term effects are, some of which will be transformational, but you don't yet know it because we've had quite a short, I know it seems long, but it's still actually a relatively short timeline of a year or 2 or 3 max for most of these sites. So
Or maybe is it really about the things that you highlighted in the external part of the updated version of the framework, really in relation with transformative capabilities of systems? I was wondering, as you both mentioned, from Ala's presentation, Marianne, everyone mentioned, so I ended up saying, what is it with transformative capabilities, and really, how can we push it forward? In addition, of course, from an empirical perspective, as you mentioned, Sophie, maybe the timeline of the project, but generally speaking, for practice, is it really the impact of these connected systems? Karen also mentioned, the political constraints that maybe are more linked to this transformative capabilities. Any further reflections from your end on that?
I mean, just to say, when I put up our overall research question at a meeting, they looked at me as if I was mad. And the answer was, of course, you can't do that. How can you build a gender equitable, sustainable system in a fragile, I mean, it seemed like that was a very ambitious goal. So let's also bear that in mind. Yes, transformation is hard. Transformation is hard in any system, but we're talking about environments which have been continually bombarded by shocks and crises ever since we started this work. And let's face it, they probably won't stop now because the world has got even shakier. So I think not collapsing is already an achievement, frankly, in many environments. We need to also have some realism about the environment we're working in. So if you can go in and stop a system from collapsing, you might have done the most important thing. And it hasn't transformed. Well, so what? It's in an acute crisis mode. Transformation, then we can look at longer term if it stabilizes. But we are in very challenging environments. So I also think let's be idealistic, but realistic.
Yeah, I agree. I think we do need to be a little bit idealistic. We've got to have ambition. We have to. otherwise we don't move forward with anything. So yeah, there is a sense of realism around it as well, but there's a balance. Yeah. Yeah.
And without neglecting, I know just for
Yeah.
also the audience, colleagues on the Rebuild Consortium also discussed the types of shocks, etc. So
Mm.
we're not
Mm.
neglecting sometimes the magnitude of shocks, right? So systems can sometimes not be able to cope with extreme shocks, and this is a good point. So now I'll take another example from the Q&A box. It's about how unique are the key lessons and frameworks to FASP, do you think? So in other words, if I can add to it, what do you say about the global resonance of R4R findings? In a sense, we focused on some settings, but do you think that this is we can transfer this, or it has a global resonance beyond these settings that ReBUILD studied?
I mean, just to be clear, although we had 4 core partner countries, our studies actually drew from 23 different countries in the end, because we had a lot of connected and affiliated studies and responsive funded studies. So we did quite a wide range of work in a range of settings. Each of those settings is completely its own place.
Yeah.
And this is obviously something we come up against all the time, this importance of context. So you can never generalize, even from one fragile shock-prone setting to another. You can't generalize. They're all importantly different. But I think we did get findings from quite a wide range. So I think we can speak in a general sense to those kinds of contexts. And I also think it's really important that we did, because very few studies are actually focusing on these settings. I work a lot with colleagues at places like WHO. They do a lot of really important work. What's striking is how the fragile settings are so rarely at the table, because they're hard. So models are always tested in more stable settings. How many groups are really looking at fragile and shock-prone settings? It's unbelievably rare. So I think our work is really important, because it filled what seems a massive hole, given that these are the settings where most of the health problems are, and it's increasingly the case where the acute problems are. So I think that doesn't mean we did everything. It doesn't mean we answered all the questions, but we were doing something that was really important. I hope it will be continued. It's super significant, and there's not enough of it happening.
Thank you, Sophie. Joe, any reactions from your end?
No, I think, I mean, I think what we were trying to do as well was look for patterns and look for things that were kind of, you could see the different types of responses that were happening in different settings, and try to generate evidence and learning from that could be used more widely, not just in those settings as well. So that was quite a lot of our sort of synthesis and synthetic work that we have tried to do and pulled into different papers within the special issue as well. So that really try to make the lessons that we've learned more applicable to across lots of different sort of settings as well.
Thank you so much. I'll move now to a couple of questions focusing on the AIDS cuts specifically, and also, I mean, I would like to invite Ala if you'd like to add as well. So it's really questions to all panelists and discussants. The first question was about Julie saying that, I'm interested in governance response of community health system to financial disruptions and shocks. And how can we go about such a study? Sorry, I meant Marianne as well on the AIDS cut. I'll get back with a series of questions on the diaspora contribution. And there is also another live question asking what can we learn from ReBUILD's year of work as LMICs grapple with the realities of the massive donor cuts for humanitarian and development funding? So this is also another reality. Does financial shocks impact the health system much more than other type of shocks and fragility? And this is again going to the point, did we see really kind of synthetic evidence about shocks being more impactful on system and on their resilience capability than others? And the example here is the financial shock itself.
Well, I'm happy to kick off on that, but you're also an author on the paper, as is Marianne. So anyone can answer really. But I think on the aid cuts one, we tried to look at the early reaction and whether countries had been able to deploy any kind of coping strategies. And what was striking is 2 countries really had much higher degree of dependency, and you see a more immediate impact on the services, but also more difficulty in adjusting because there's also a habit of dependence on aid. So it's important to understand, of course, that there's a lot of, as speakers highlighted, a lot of political economy around these, but also institutional patterns of ways of thinking and behaving. And so in some countries they changed the rhetoric, but they're still kind of waiting for the aid to come back because there's been such a long-term history of relying on it to fund core services. Whereas in the other 2 countries, there was a slightly different relationship where aid was being used more in a kind of system supportive strengthening way. And in those contexts, there's more ability to adjust, there's less immediate impact, but there is also across all of them this risk that essentially the system strengthening gets lost, everything gets focused. After all, one resilient strategy is focusing down, saying, what do we really have to prioritize? And that's fine, but obviously you prioritize life-saving. And then what you find is all of the training, all of the information systems, all of the system strengthening kind of gets dropped. So there is a risk that we look at those countries and we think they're coping, but what's happening is degradation of quality over time, and that will only play out, in the next few years. So I think the message is kind of clear, isn't it? That rapid transition is totally irresponsible from an aid side. But yes, countries also have to step up, and some of them can, and some of them have been. But also that those system strengthening elements have to be protected, that they're not optional extras, because actually that's what saves lives over time, in the medium to longer term. But I'm sure there are other messages. What would you pick out, Ibrahim?
Yeah, no, I mean, for me, just to add, and I saw Marianne maybe also would like to add some other messages, but just to add, really, as you said, sometimes really with the shock, specifically the financial shock, whether from aid cuts or economic crises like in Lebanon and other places, unfortunately, there is an opportunity to transform this system, but sometimes it's missed because, as you said, it's a kind of a past dependency and reliance on aids that will be there again. So really kind of just to echo this point. And Marianne, would you like to add any specific messages here, please?
Yeah, one more point. A lot of interesting findings are in the paper, so I really encourage people to read it. And we had to present very briefly our findings, but it's not only what we mentioned. So the response is really shaped not only by the volume of the cuts, but also by the nature, which I mentioned, and also how abruptly it occurred. So in Nepal, for instance, decrease in funding started a decade ago. So they had time to respond differently compared to other countries where it was really abrupt. And I would say it's a double responsibility. Of course, governments have to cope with these funding cuts, but it's also the responsibility of the donor to prepare for these transitions. So some initiatives have been funded for like 10 years with no exit strategies in place, no sustainability plans in place. So this is also something that I don't know, but a debate should be initiated by governments. We're happy to transition, but we need support and more, maybe one more grant cycle or one more grant to prepare for this transition. So to sustain, service delivery, but also the whole things that come with the training, capacity building, and so on and so forth. So that's it for me.
Thank you so much.
And the failure to build capacity over a long period of investment is quite an indictment in many ways of what aid, because what this is making us do is think about what was aid doing. And frankly, there's a lot of questions about that, about the aid effectiveness, which maybe are good because it means in some cases they can substitute for it relatively effectively because a lot of the aid wasn't being used, in an optimal way. So I think the paper does raise a lot of questions. And Maria is also on the panel, if you wanted to add on that, Maria. We have a lot of authors here.
Yes. Yes, no, I think I think you all covered pretty much everything. I think there's, I think there is a sense, obviously, having worked quite a bit on the case of Sierra Leone, there is a sense of really the missed opportunities in the past and in the present to kind of support the health system, and also the kind of terrible consequences, immediate consequences for the population. So, and I'm thinking here of a Saving Life Sierra Leone program that has been so abruptly interrupted. So yeah, so it is a very difficult conversation, and it's really hard to kind of go back in the past, but I think it must be really a call for action by governments and also by funders in terms of how do we fund the health system, and again linking to my intervention and something different. And I was just typing now some answers in the chat about health system strengthening and the importance of health system strengthening in humanitarian setting and in fragile setting where it is difficult to do it, but it's worth it because it will be the sustainable thing to do in the long term.
Thanks, really.
Just add one thing, Ibrahim. We've
Please.
looked at the resilience of the health system, but also the question is, what's the resilience of the donor ecosystem? And I think that's a whole nother interesting question. So one of the things we tried to look at, but very briefly in this, is how did aid respond as it dropped? How were the funders able to adapt, flex, change the way they're working, work together better or not? And we have some interesting, I won't go into it now, but we have some interesting insights on that in the paper as well. So I think they are the other side of the story. It's not just, as we've said, about the health system, it's also about the kind of aid ecosystem and how it works or doesn't work.
Yeah, that's a very important point as well. With other involvement with other consortium, we're looking also at the kind of the gaps in the humanitarian system. So sometimes, yeah, again, and I had in mind while colleagues were presenting sometimes about the tension between different elements of the system. I was concerned also whether, focusing on community health system, whether really somehow we're putting pressure on them and risking the fact that resilience is becoming a normative expectations placed on community, rather than on institution, or as you said, it's on the system rather on the aid system or the humanitarian system. So really kind of sometimes we might be risking to shift the resilience focus into some places without acknowledging the other places or other parts. I have an interesting question from our dear colleague Munzer Khalil as well on the clear whether we had a clear connection between legitimacy and resilience in health systems in conflict and fragile settings. And I have a good suspect for this question, but I'm not sure if anyone would like to volunteer before. I'm not sure if Fuad is still with us online and would like to
Yes,
take.
of course. Yes, of course.
That
This
was
is my
my
suggestion.
idea as well.
Where to go?
Give that to Fuad.
Yes. Well, no, I mean, definitely this is like and thank you for Munzer for raising this issue. I mean, I also see that also Sophie mentioned that in this new framework that when talking about this for side undecided framework. So I think yes, legitimacy is a new concept to think about it when thinking about this health system resilience, and we see that when in many settings where the government is part of the conflict and not like just a sort of a neutral entity. And that's when having what in other paper published about this issue of limited statehood, where specific territories ended up to be for a long time, for protracted time, sort of self-governance. So I think that's sort of the question of legitimacy raised here strongly on be part of the process itself. But yeah, I guess I agree that it's good to think about all these political dimensions when thinking about resilience. Health system resilience can't stand alone by itself as a sort of only one system resilience. It's always thinking about multiple system resilience at the same time. But Sophie could also engage with that.
Yes. And also just to say that as you clearly heard from the panelists, the role of non-state actors is key across all the settings, which means that kind of if they are not getting their legitimacy from hierarchical power kind of structures that are getting legitimacy from somewhere else, probably from community perspective, and this is key. And I think if I'm not
It's
sure,
very controversial, by the way, I mean, when talking about the legitimacy of non-state, it's a de facto, but sometimes it's a controversial, and that's the issue sometimes.
yeah, and I think I have a follow-up question while waiting for another interesting questions from the audience, because I think if I'm not sure if Karen mentioned it about, and Sophie reiterated that the relational kind of, the importance of relation between different actors, trust, and these specific relational dynamics. And I know that a paper looked at this relationship between actors. And would you like to add anyone really more insights on trust and between actors and the role into building a resilient health system, if I may say?
I mean, I think that theme came across all the papers, but it'd be nice if Karen wants to add a bit because
Yeah,
she worked
maybe.
on a paper on governance and actors. Yeah, over to you, Karen.
Thank you. Yeah, maybe I'll just add one insight, and I think the actors panel kind of reflected on this. And as you've said, it's often about the relational aspect. So not just who has formal legitimacy or institutionalized legitimacy, if you like, to engage in a response or to do something, but also what are the more informal networks, who are the trusted relationships that can be mobilized. And I think something we've seen in our work is that is often, as we've said, left to the informal and left by the wayside, but actually is able to then mobilize huge resources. And often resources are not just financial, it's also about the knowledge. How do you actually engage with certain populations? How do you, formulate messages that they might adhere to or think about differently and so forth? So I think what we've seen is that we have to be careful to build trust. And I think Jana rightly then reflected on that also takes capacity for us as researchers to engage better and in different types of soft skills with the communities we work with, so that they can themselves also mediate any difficulties they might have between different groups, and build trust going forward.
Thank you so much, Karen. And we only have
to say that links very much to the discussion around the diaspora as well. So when we think about aid, it's not just about the money, as Marianne was saying, it's also about the kind of quality of that, the relationships that build the capacity that's transferred or not. And one of the questions now is, if diaspora ends up substituting to some extent for formal aid, are they going to build those relationships any better? Because it feels like a lot of the aid was bringing in resources, but wasn't necessarily building the systems that effectively. But are these more locally connected actors going to be able to do that better? And that's one of the things that would be really interesting to test going forward.
Amazing, thanks, Sophie. And I saw really engaging discussion on diaspora. And just to say to everyone in the audience, please feel free to write to corresponding authors, to lead authors, to ask more questions if you'd like, and to read the papers. I think I've got one last question. It's about really the challenges. The question says, I work with humanitarian funders in various healthcare settings, and I'm always trying to encourage them to take the long-term view, as this approach is so important in system strengthening. Maybe in 10 or 15 or 20 seconds, although it's not enough for this question, really, this issue of short-termism in humanitarian responses, neglecting the long-term view, although we all know that a resilient health system doesn't mean a strong health system, and a strong health system is not really as, sometimes as automatically resilient as we think. But yeah, what would be the way to push humanitarian actors to also make this humanitarian development bridge? Maybe Maria, quickly, if you'd like to say anything on this based on the health system strengthening paper.
Yes, thank you. And I have already posted quite a bit on this, so perhaps you can refer. I think everybody can still see them, even the answered question, hopefully. But yes, I think this is really important. And I think just opening the conversation and reminding the humanitarian actors, implementers, and funders about the importance of health system strengthening. I think if, that had to be the message, I think that's really the best starting point. And then exactly how to do that obviously depends on the content. And I gave some links where we kind of go a little bit in more detail about these processes and about also the learning agenda for implementing actors and funder to kind of switch from a more service delivery focus to a broader health system strengthening. And again, as I mentioned, our Tigray paper, and Ibrahim, you're one of the co-authors, really shows the things that work, in the short term only, and the things that can work both in the long and the short term. And unsurprisingly, trust and working with communities and leadership come again as one of the kind of key resilience capacities. So we're kind of closing the circle and everything matches.
It all links together somehow.
Exactly. Somehow, so it does. And so I think it's kind of strengthened our findings that there are so many kind of overlaps from different studies looking at very different things, but coming to show the kind of the same points. But again, so I think humanitarian actors obviously have a focus on service delivery, but sometimes it can be very short term. And in the longer term, we see that it might not be what is needed. What is needed is a bit more, I can focus on relation, on long term, on legitimacy of actors and so on.
Brilliant, thanks a lot. And I've got one reflection also on the term non-state actors and how to distinguish this from a violent non-state actor. I think the quick reaction is, yeah, I mean, the term comes from international relations, I think discipline, and yeah, the ReBUILD team used it. But of course, there are subcategories within that maybe.
It's very broad. It's very broad. It's very open to debate. But yeah, look at the paper and let us know what you think.
Amazing. Thanks so much, Sophie. I'll stop here and I'll hand it back to Egbert for really the closing notes. Thanks.
Thanks, Ibrahim. And yeah, I think the only thing that's left for me is to thank everyone, in particular all the panelists who had the difficult task to say something in very short time available. And I think you did very, very well. And it must have been frustrating here and there, but I think it did show the richness of what ReBUILD has brought us. Thank you also for the discussions at the end and the final discussion, including the audience who brought in highly relevant points. And I think it was a rich discussion as well. And I think all this reflects the richness of what ReBUILD has and ReBUILD for Resilience has brought us in all those years. So I think really that this special issue is just kind of the top of the iceberg of what ReBUILD has been producing. But I think it's a kind of a bit of a lasting heresy. So I think if dust settles and if ever there is, again, a bit more resources, a bit more interest to do more research, as Sophie clearly indicated how relevant it is, that we can build on resources like this, which are easily available, also thanks to the social science and medicine. So thank you all, and I think this was it for the time being. I'm sure there will be a follow-up communication coming from Kate to all of us to keep you informed on developments. So thank you very much.